I'm Bruna Ventura, and we're here at the 2022 BRASCRS meeting in Salvador, Brazil. And I'm having the pleasure to interview Dr. Ashvin Agarwal that came all the way from India. Welcome, Ashvin.
Thank you. Obrigada.
Oh, very good.
Obrigado.
Obrigado.
I forget it.
Obrigado. In the meeting, you presented a technique that you developed. Can you talk a little bit more to us about it?
Sure. So this technique is called the vitrectomy-assisted phacoemulsification, where we are in the middle of phacoemulsification procedure doing vitrectomy intermittently. The reason we want to do this is because in a lot of cases or complex cases, we have something called as aqueous misdirection. So when the aqueous goes behind the posterior capsule, hydrates the vitreous and causes a sense of positive pressure. To avoid this, what people usually do is put iris hooks, or they put a capsule tension ring, or they start injecting more and more viscoelastic. This honestly does not solve the problem. Instead, it can cause more problems because you're at the same point putting a lot of BSS inside the eye. And this BSS goes and hydrates more vitreous, causing a chicken and egg story of round circle. To avoid this problem, what I started to do was to actually place a trocar behind the limbus, behind the 4 millimeters from the limbus. So it's directed behind the posterior capsule. And once you're there, you use an anterior vitrectomy port, push the bevel of that port down so it does not capture the capsule. That's one way to avoid problems of capturing capsule. Push the port down and just for 6 to 7 seconds, push down on the vitrectomy cutter at 1,500 cut rate. If you do this calculatedly, intermittently, whenever required, you will start to see that the space that the anterior chamber gets is a lot more. You will start protecting your capsule from injury. You will protect your corneal endothelium from any damage that the ultrasound might have had because of a shallow chamber. This is what the biggest advantage it comes when we start to do cases like aqueous misdirection, or we have a really tight intumescent bag which has a very shallow chamber. So you want to create that space from behind so that the bag complex goes down and you're creating an anterior chamber depth that's deeper.
Wonderful. I saw your videos, and one question that came to my mind is how to know because when you have a initial nuclear sclerosis, you see the tip of the vitrector. But when you have an advanced cataract, how do you know that you're inside the eye? Like, how do you direct the entrance of the vitrector?
So that's a fabulous point, and unfortunately you still have to know a little bit of how trocars work. So the way that trocar works is you need to direct it both to, one is towards into the sclera, and then once you break through the resistance, then you change direction and go to the center of the macula. You don't go to the center of the pupil because then you're going horizontal. So in your mind, in your spatial mind, you need to direct that probe directly to the macula, and you'll be through. Make sure you're at 4 millimeters from the limbus. 3.5 to 4 is okay. Anywhere in between that, and you're sailing through in this.
Wonderful. And the last question. So how to avoid the posterior capsule?
Yeah, I think that is one of anterior segment surgeons' biggest nightmare. Because I'm asking you to use a vitrectomy cutter behind the capsule, and it's really close to the capsule and you can damage it. So the way that I have started to realize how to avoid this is simple. When you go inside, first of all, turn the port direction downwards. We don't need the port direction to be facing us like you would in an anterior vitrectomy. Here you're doing an anterior vitrectomy, but you're doing it with an intact capsule. So you want to turn that bevel downwards and direct it again to the macula, and now start pressing on that foot pedal so that you can cut vitreous. Just 6 to 7 seconds in that burger space, two things are happening. One is you're cutting vitreous, and you're aspirating the saline or BSS that went in. So those are two things that are happening.
Wonderful. Thank you so much, Ashvin, for coming for our meeting and for this wonderful interview.
Thank you, Bruna, and it's always a pleasure to be, interviewed by one of the most popular Argentinian doctors, Bruna. Thank you so much, Bruna.